Hello, and welcome to CAPS 2022 and the presentation called Sex Therapy Assessment Strategies. Hi, my name is Dr. Andrew Mercurio. I am Professor of Marriage and Family Therapy and Director of the MFT Graduate Program in Nyack College, which is located in New York City. I'm also a sex therapist, certified sex therapist, and ordained pastor. Sometimes when I say that, actually, in presentations, people who are in the audience might gasp, how can you be a sex therapist and a pastor? God and sex, how do they go together? Well, I think they do go together. I think sex is a good thing. It's a God thing. God created it. And unfortunately, it's been distorted, polluted in so many ways, apart from the beautiful biblical purposes that I think God intends sexuality. Throughout this presentation, you will have opportunity to record your thoughts or questions in the chat room. And I encourage you to do so. I'll try to interact with you throughout the presentation. And afterward, we will have a Q&A time. So again, welcome to this presentation, and may the Lord bless it to you. So I want to start by looking at objectives. Basically three objectives for our presentation. We want to look at 4 sex therapy assessment strategies: the sex scan, the source model, the secret model, and sexual preference zones. Second, we want to describe the systemic interplay and reciprocal influences and interactions between various sex therapy issues that are clinically evaluated. And third, we want to look at factors for selecting and sequencing sexual assessment interviews to best formulate a comprehensive clinical treatment plan. What we will not do and learn and focus on in this presentation, we will not focus on assessment strategies for sexual trauma or sexual compulsivity, gender dysphoria, nor will we focus on quantitative sexual measures, a number of very good inventories and psychological tests to do sex assessment. Nor will we focus on treatment of sexual difficulties or disorders. Primarily, we're going to focus on assessment in this presentation. It is my very firm conviction that often sex therapy goes awry and is problematic because sex therapy assessment is very poorly done. So we will look at the clinical issues related to the DSM disorders. For male disorders, we have erectile disorder, delayed ejaculation, premature or rapid ejaculation, and male hypoactive or low sexual desire disorder. For females, we have female orgasmic disorder, female sexual interest arousal disorder, and genitopelvic pain penetration disorder. Now, I find it very helpful when we look at sexual issues that our clients present to look at 3 different domains. Where do they fall in these domains? Are they just talking about sexual differences, which might be lighter clinical treatment, or do they focus on sexual difficulties, or do they present in a way that qualifies in a diagnostic way in terms of a sexual disorder? It's a continuum with an increasing level of severity and concern. So let's look at sexual differences for a moment. The first domain. Well, there are primary differences, yes, between men and women sexually. There's certainly similarities as well. The differences may be anatomy focused and based, and physiology focused and based, and also preference focused and based. But in terms of anatomy, some would say that women have a lot of variety about what creates desire and arousal. On a certain day, dial A, Z, and B, if touched and turned, might generate arousal and interest. But on another day, those dials just don't do it. And there can be a variety of ways that create both interest and arousal. And some would say guys, conversely, are maybe wired a little bit differently. Perhaps a little bit simplistically, touch of the button here and the on switch is up. Again, this doesn't make men better or worse than women, but I think the reality is that there are some differences. Obviously in anatomy, but certainly in physiology. In terms of the sexual response cycle, I'm amazed how many couples have difficulty because they don't understand the basic differences of sexual physiology. And sometimes the thought is, what's wrong with you? How come you're not like me? How come it takes you so long to get interested or in the mood or aroused or to have an orgasm? How come we're not like in sync? What's wrong with us? Well, typically nothing. It's just different. For guys, they can climb that arousal plateau, that hill rather fast. And for women, it might take longer to get there. And they may need longer arousal, focus, and stimulation and foreplay. And guys, when they hit an orgasm, they have a tendency to have resolution that can drop very fast. And for women, it's going to take them maybe a little bit longer. I'm talking generalities here. It may not always be for every woman or for every man. And when they hit an orgasm, they could have potential multiple orgasms, or they may not hit an orgasm at all, and that could be okay. So there's certainly differences between both men and women. And again, part of the concern or the question is this understood? And is it accepted? Or is there a sense of criticism? Like, you're not like me, what's wrong with you? Or what's wrong with me? Or perhaps worse, what's wrong with us? There's also differences in position preferences, differences in how frequently a couple wants to have sex. The wife might say, once a month. The husband might say once a day. The reality of differences is common in almost all couples. The question is, or the concern is, does a couple negotiate the differences? How about differences in terms of preference, time, place, mood, setting, ambiance, the use of sexual toys, vibrators, differences in terms of your belief about oral sex, differences about frequency, about initiation of sex, whose job is it to initiate? And foreplay, how long does foreplay really last? I've heard one wife say, I don't want foreplay, I want 8 play. I want it doubled. So there's so many differences in preferences. Again, the problem isn't that we're different. The problem is, do we negotiate the differences poorly? And if we do, then those differences turn into difficulties. Now, there are a number of reasons why couples have sexual inability to deal with differences. Maybe they don't understand the differences. Maybe they haven't discussed them, or they understand, but they just don't accept, because after all, you should be just like me. Or maybe they know the differences, but they don't have the skills to negotiate their sexual differences. And part of this might be systemically related to the fact that they don't negotiate differences in other areas of their marriage, in their financial differences, their parenting differences, their differences about responsibilities of chores around the house. And some couples just do not negotiate differences well. They don't have good conflict management skills. So when it comes to sexual differences, well, they're in the same place. And for some, they have problems with what I call lack of sexual differentiation. They don't really know what they want and need sexually, or if they do, they don't express it because they feel too embarrassed, or they feel their partner will never give what they want. Or maybe they have low entitlement. They don't feel like, I'm entitled. Sex is about you. It's not about me. So I think these reasons play into sexual differences becoming sexual difficulties. And then the difficulties, if not dealt with well, in time might morph into sexual disorders. Now, the DSM disorders have all these criteria, checkpoints that need to be met. And if so, it becomes diagnosed as a disorder. But all of the difficulties sometimes have features, but not all the criteria. You can have borderline personality disorder features, but you don't have all the criteria to be diagnosed as borderline. But you still have many features that create many difficulties. So it's still clinically a need, a concern that needs to be addressed and looked at. So we do have specific criteria in the DSM. We have common criteria for these issues: frequency, duration, distress. Frequency for most of them, at least 4, are on occasion 75 to 100% of the time. Duration, to be diagnosed as a disorder in the DSM, 6 months. So if a guy comes in with erectile dysfunction or problems, and we ask, how long has this been at play for you? And he says, 4 months of agony. Now, we don't say, come back in 2 months, and if it's still a problem, I'll diagnose it and we'll do work. Now, right now at 4 months, we can't code it, but we can basically still work with him and them as a couple. And the subjective distress, significant distress for either one of them or both of them as a couple. Now, sometimes there are issues that maybe we think are problems, but they're not problems for the couples. Women could say, I don't have orgasms, and that's fine. I have great sex. I have great closeness with my spouse. I don't need orgasms. I'm not bothered by it. My husband's not bothered. There's no significant distress. So we can't typically code that as a orgasm disorder because it doesn't meet the distress criteria. So assessing the domains on the continuum from difficulty, differences, difficulty, disorder may inform us the kind of treatment and care to provide. If it's differences, then maybe they don't need sex therapy. They need sex education to understand. There's so much mythology and so much poor information and unrealistic expectations about sexuality that is so sad. And sometimes some good sex education to help understand the differences and then to negotiate the differences. Difficulties maybe need sex enrichment, some good skill learning ways to negotiate, some skills of different things to do in communication and behavior to enhance sexual fulfillment. And for significant sexual disorders, we're looking at more classical sex therapy, the Master Johnsons, Kaplan, and more current modern forms of sex therapy today. So 3 levels of sex therapy related to this. Level 3, which I already spoke about, is treating sexual disorders. But also I think there are 2 other levels: building relational intimacy, level 1, and facilitating communication and negotiation, level 2. Both, I think, are part of sex therapy. So let me talk about that first one for a moment, building emotional intimacy. If a couple comes to me with a sexual issue, before we get into much of the detail, I'll ask them, tell me about your relationship in general. And if I find out that they are very conflicted, they are very troubled, there's lack of trust, there's lack of attachment, there's unresolved issues, they really don't like each other, then typically I'll encourage them to say, the sexual issues, let's put them over here for now. Let's focus on building the secure attachment base for the marriage. Let's focus here. Because I've found that many sexual issues that couples have are symptomatic of a poor, conflicted, or poorly attached relationship. So I'll work on the marital issue, doing marital therapy for a period of time, shoring up that base and that foundation. And once that is built and secure enough, after a period of time, I'll come back and say, you know, let's take the sexual issues off the shelf. And I think we're ready to deal with some of these things. And you know, sometimes to my dismay, this is what I hear. You know, those sexual issues that we were concerned about initially? Well, guess what? They're not issues anymore. They're not problems. They've gone away. Sometimes sexual problems and difficulties are symptomatic of a poor relationship. So sometimes just doing good marital counseling can alleviate some of the sexual problems. Not always, but sometimes. That's level 1. Level 2, facilitating communication, right? Sometimes couples just don't communicate about sexuality because it's too embarrassing. After all, doesn't social media and Hollywood say if you're really a good lover and you love each other, you just know how to do it without having to talk about it? And if you have to talk about it, then it's not spontaneous, it's not romantic. Again, so much mythology and poor understanding about sexual intimacy that messes with the greatest sexual organ right here, our brain. So a lot of couples don't talk. I heard the story of a guy who, he and his wife had some good sex for 30 years of their life. They had one position. There's nothing wrong with one position. If that works for you, it works for them very well. But he had a car accident. He hurt his back. And now when he's intimate with his wife, his back really hurts. So they basically said to themselves, you know what, Martha, he said, we've had a lot of good years. We had a 30-year run here, but you know what, this is hurting too much. So why don't we call it a day? And they stopped being intimate because it hurts too much. You see, for them, the fix is not really too difficult. What they really need to learn are maybe a different position. But to do that, here's the trick. They have to talk. And some couples don't know how to talk very well. It's too hard. It's too embarrassing. It's too shameful. So sometimes facilitating communication and being a coach to help them talk and giving them the language to call their body genitals what they are and to talk about things and to make that more of a comfortable dialogue can alleviate a number of very deep and significant sexual problems. So sometimes that is all that people need. Okay, so let's go back to our screen. Building relational intimacy, facilitating communication and negotiating differences, and then classical sex therapy, treating sexual disorders. Okay. So again, level one, how's the relationship? It's not a good time to do in-depth sex therapy. It's counterindicated at this point if the relationship is not well. Let's focus on building the foundation. Level two, let's facilitate communication and negotiation. How do you negotiate differences? And again, for some couples, they don't negotiate differences in the bedroom because they don't negotiate differences in the kitchen or in the garage or in the living room or in the control of the TV room, so many places. In terms of communication, I like to share a model related to food, which is the first assessment called sexual preference zones. And this is an interview I'll do with couples, and I'll share this image. So I like to think about sex and food. I don't know if it's the Italian in me or not, but sometimes I understand psychological concepts through food metaphors. Not sure what that's about, but I'll share this image. And I find most couples, I find it's helpful for them. So say the guy here in his circle, he really likes eggs, ham, and steak. And the woman in her circle on the right, she really likes peas, lamb, and steak. Now their circles overlap, and zone A is where they overlap and where their preferences overlap, and these are the priorities. These are things that they both really, really like greatly. So the question here is, how much steak should this couple serve up in this relationship? And I think they should have steak quite a bit. They both really enjoy steak. But how about zone B? These are preferences that each individually have, but are not shared preferences. So the guy really likes eggs and ham, but the woman, no, it's not in her circle. She says, it's okay, but I'm not crazy like you are about them. And conversely, she likes peas and lamb, but he's like, you know what? I can eat peas and I can eat lamb, that's fine. But I'm not like crazy about them. But you know what? Because I love you and I want to put a big smile on your face, I'm going to cook up some good peas and lamb tonight. And conversely, she says to her husband, tonight, I'm going to make it an eggs and ham night. I'm going to give you something tonight that I think is going to really be fun for you. Now, again, this is giving to each other, being a servant, loving each other, mutual submission, care for each other. Ephesians 5:21, being loving and giving in such a way. So that's zone B. Zone C are the prohibitions. These are things that they don't like. The guy, if he eats squid, he gets nauseous. The woman, if she eats squash, she breaks out in hives. So question is, how much squid and squash should there be on the plate? Not a whole lot. Okay. Now here's the challenge. What if squash is in the circle for the guy with the steak, eggs, and ham, and he really loves squash, and he wants his wife to enjoy squash. She's like, I can't handle squash. Well, it's an unloving and unrespecting thing for that guy to push squash on his wife. He can ask for it. I think we should be able, healthy communication in a relationship is asking for what we want and need, but not demanding it and not pushing it in a way that is disrespectful. And sometimes in sexual intimacy in a couple of relationships, the C zone is pushed and pressured and guilted, or guilt is given to the partner if they can't enjoy it the way that I do or that I would want in our relationship. So I'll give this silly model, but it kind of takes away a little bit of the anxiety to do so, to talk about sex in this way. So I'll ask, what are your zone A's, B's, and C in your sex life as a couple? And if the couple's comfortable talking about that in session in the office, we'll do that. If it's too personal, I don't push that. I respect that. I give that as an assignment, an exercise for them to do at home. And then to come in and talk with me about, what was it like? What did you learn? How did that help you? I don't necessarily need to know all the nuanced details, but I'm learning. I wanted to learn about the process of what it was like and how it enhanced greater communication for them that often can help with whatever sexual difficulties they're experiencing as a couple. So again, 3 domains and 3 levels. We've looked at sexual preference zones with this illustration with food as our first assessment. The second assessment is what I call the sex scan. So the first one, in the sex scan, what we're doing is we're basically getting a good overview. It's like there's a forest on fire, and we're in a helicopter flying over the forest, and we're getting a bird's eye view of the lay of the land here, what's burning, what's hurting in this forest. The sex scan is this generalized flyby overview, and typically I would do it in one session. It can take anywhere from 10 minutes to 20 minutes, maybe 25, but not too long. But it's a self-report interview, and it looks like this. Well, actually, it doesn't look just like this. I kid with my students and say, down the hall on the 17th floor, there's a doorway. You go through that, and there's like it's not an MRI, it's a sex scan machine, and that will tell you. I'm just kidding. It doesn't look like that, but it looks like this. There are 4 areas of the sex scan that are evaluative areas: desire, arousal, pain, orgasm. This is the generalized flyby overview to see what's at play. So when I'm doing the sex scan with a couple, I have this chart on my pad of paper in front of me. And basically I have all the clinical disorders plugged into the chart, and I'm interviewing them. And I'm describing not the disorders with clinical terms, but with more perhaps lay language terminology. And I'm asking them basically, does this relate to you? Does this apply to you? And they self-report. So I'll say, okay, desire. Desire is libido. Desire is your interest in sex, your sense of being turned on, how frequently you think about sex or fantasize about sex. You know, the sense of your libido, your sex drive. And I'll say that to normalize, men and women in couple relationship have a desire differential, discrepancy, which is normal. Very few couples have the same exact libido level. It's more typical that they have different. That's not a problem. The only problem is if we can't negotiate the difference in a way that's mutually beneficial. But desire becomes a problem if it's maybe way, way, way too high. People are maybe way obsessed with it. It becomes the most important thing of a person's life, the most important part of the relationship. Or if it becomes too low to the point of I have no desire or hardly any at all. Or even worse, sex is kind of gross to me. So the question here is, I'll ask the couple, is it ever perceived for yourself or your partner as way, way too high or way, way too low? And I'll have them report on that. And then we'll talk about arousal. Arousal is physiological arousal. It's the same physiological mechanism, blood flow to the genitals, creating a erection for the man and creating lubrication and engorgement in the genitals, the labia, and the clitoral area for the woman. And I'll say, here are the issues of concern for some people. For the guy, it might be that he doesn't have an erection as often as he wants, or the quality, it's not as strong as he wants, or he loses it more frequently than he wants, and he's really bothered, or she's really bothered, or they both are. For the woman, all women may have periods throughout their menstrual cycle where they have hormonal shifts, where they may have more, engorgement, more lubrication, but this is persistent sense of lack of sensitivity in the genitals, a persistent sense of dryness or lack of engorgement, regardless how motivated or excited they are. It's just like, I'm excited, but down here, it's just constantly, it's like almost dead or dry, or lacking sensation. So I'll describe this to them and ask them, is this a concern for either of you? And I'll have them report. Orgasm, okay, for guys and women, there are concerns only, and at times for the guy, it might be a concern if his orgasm, his ejaculation happens way, way too fast. And this is very subjective, what's too fast? But if it's quicker than he wants it to be, or that his wife wants it to be, and it creates distress, or sometimes it takes too long, or it doesn't happen at all. And it's really frustrating for him or for her, for both of them. For the woman, it might be an issue of not having orgasms. And again, for some women, that's not a problem. For other women, it is very distressing, or it might not distress them, but it distresses the partner. For some women, it might be a distress to the point of quality or quantity. Maybe quantity, it's not happening as frequently as I want. Or maybe the quality, it used to be very strong, but now it's like, it's hardly anything, and it bothers me. Okay, so I'll describe these concerns and I'll ask them, does any of this relate to you? And they'll report back to me. Pain. Pain is physical pain. And I will say, unfortunately, this is a reality that is very, very rare for men, but unfortunately it can be more common for women. In fact, 15% of women, research is showing us, typically have ongoing, regular, persistent pain during sexual activity. And so I'll describe, there's different names of vaginismus, dyspareunia, different kinds of pain, in deep pelvic, deep pain, more surface level pain, sharp pain, dull pain, pain before or during or after penetration, or during, after, or orgasm. There's all different kinds. Some that have physiological, organics, etiology, others that have psychological, and others with a combination. I don't get into the names or the details. I don't say dyspareunia. I'll just say pain. I'll give general descriptions. And I'll just ask, is any of this at play for either of you? So I'll get the sex scan and I'll just check anywhere in the box where they report. Now, by checking, I'm not assuming this meets the DSM criteria, but they are identifying it as a difficulty. Is it a disorder? I don't know yet. Again, this is a bird's eye view, a flyover of a self-report. But why do we do this? Because I've learned over the years that sometimes when individuals come to sex therapy and they start with a presenting problem, they may show you one thing, but not other things that are behind the door. So the woman might say, yeah, I've got low desire and I need therapy for it. Or the guy might say, I've got low desire and I want therapy for it. But the guy's not going to say, you know what? I've got erection issues and it bothers me. Because sometimes guys are going to be too proud to acknowledge that. They may not volunteer that in the intake. The woman may not volunteer, oh yeah, I've got pain as well. Because maybe they don't feel entitled. Maybe they were taught you just kind of, grin and bear it. That's what women do. So they don't report pain, maybe not even to their spouse. So by doing a sex scan, you are giving them an opportunity to look at all the different areas, and you're basically putting it out there. These are all areas of concern, and it gives them an opportunity to say, oh yeah, by the way, there's this as well. Now, when we do this, we have different members of what I call the sexual family system. Just like in a family system, different members of the family interact and interconnect and inter-influence. The different sexual problems in a couple's relationship interface, interact, and inter-influence each other systemically. So you have a guy with low desire, and also in the sex scan, we have erectile issues and problems. So the question is, systemically, how do these two interact and how do they dance? How do they interface and inter-influence? Which comes first, the chicken or the egg? It could be the man has low desire first, and that led to erection issues. Or it could be he's had erection problems, which influence low desire. We don't know. And part of knowing the sequence, not only how they interface and influence, but which sequentially goes first, can impact our treatment focus. Because typically, not always, but typically we want to start historically with what started first. Another example, well, the same example, but you add the relational component, and now the female has an orgasm disorder connected to the male low desire and erection disorder. Now, was this a result of his low desire and erection, or did the low desire and his erection disorder result from her orgasm disorder? Again, how do they influence each other in the family system of sexual members? Here, the guy has premature ejaculation and erectile disorder. Can you have both at the same time? You can. But typically, one might come before the other. Usually it does. Often, but not always, erectile issues later on create premature ejaculation. And now you add the spouse, and she has hypoactive or low desire. Did she have that first? And does that contribute to his premature ejaculation? She's not in the mood, I just want to get over and spare her. Or does it create this erectile disorder? She's not interested in me, and that kills my mood. Or did it start with him? And the problem is not pinpointing who started it, but it's a dance. And the dance systemically feeds each other and sustains the issue, the symptom in the system. Here you have a woman with low desire and pain. Which comes first? Well, maybe the pain did, which started killing her desire or lowering her libido. Or it's possible that it goes the other way. And then you bring the man into it, and maybe he develops in time premature ejaculation. And maybe he does so because he wants to help his wife. He wants to, maybe on an unconscious level, make it a quick thing so it doesn't create discomfort and pain for her. But maybe on the surface, he doesn't like premature ejaculation, and his wife doesn't like it. So I want to try to change it, but part of him needs it to help her. So part of him wants to get rid of it, part of him wants to hold on to it, and he's kind of stuck in a conflict there where he doesn't progress with that issue because it has two different, it serves the system in a way as well as irritates the system. So again, in the scan, we want to identify what's at play and then ask how are they sequenced as family members of the sexual system? How do they support each other? How do they influence each other? And it's interesting when one problem, if there's multiple issues, when one problem's resolved, often another problem emerges in the system, in the couple relationship, to maintain that homeostasis. So we've looked at sexual preference zones. We just looked at the sex scan, this flyby overview of the different fires in the forest. And now we're going to have more of a detailed evaluation of what we've identified in the sex scan. We're going to actually land the helicopter into the fiery problem places and do more of a detail. So if it's premature ejaculation, we're going to land the helicopter there and do more of an assessment. If it's an orgasm issue, we're going to land the helicopter there and do more of a detailed assessment. So I'm using an acronym, the SOURCE model, which stands for Scan, Onset, Universality, Response, Course, and Etiology. The sex scan we've already done, which is basically looking at the overall issues and what's at play in the relationship. Onset, when did the problem originate? Was it there all their life? Let's stick with low desire in women. Now, guys can have low desire as well, but I started with that that example. So let me continue with that. So if the woman has low desire, she could say, I've had it all my life. I've never really had high desire, even moderate desire. It's always been like subliminal, really low. Or she might say, yeah, it wasn't always like that, but 5 years ago, it just dropped. Well, what happened 5 years ago? Well, my husband had an affair. My father died of cancer. I was in a car crash. I hurt my back. So we want to know if it was acquired, and if so, what was the context in the relationship, in life in general, or in our own health that's contributed to this, because that could be part of the clinical work of what has created this and maybe what sustains it to some degree. Universality. When does the low desire occur? Now she could say all the time, which is generalized. No matter what, if I feel good physically, it's low desire. If I'm having a great day at work, it's low desire. If I win the lottery, it's low desire. If my bowling team wins the tournament, it's low desire. No matter what, it's low desire. We could be in Hawaii at a beautiful hotel, it's low desire. It's all the time. Or it's situational. Sometimes it's there, sometimes it's not. Sometimes it's low, sometimes it's medium, moderate, sometimes it's high. And that gives us a lot of room clinically in terms of treatment. We could use a solution-focused approach. When the problem's not a problem, when you have higher or more moderate libido, what is going on there? What's the context? And can we identify and amplify that exception? So the assessment informs the treatment in many ways. Response, how does the client respond to the problem? So I'll ask the woman, I'll think of the acronym CAB, C-A-B, cognition, affect, behavior. When you have low desire, how do you think about it? What does it mean to you? She might say, it means I'm a loser. I'm a lousy wife. It means that my husband doesn't love me. It means that life is over. I'm getting old. I don't know. I'm broken. What does it mean to her? And why do you think this has developed in you? What is your thoughts about the origin or cause of this? I'm curious as a therapist to understand her thought process. How about your feelings? How do you feel about this? She might feel embarrassed. She might feel angry. She might feel sad. She might feel scared. Will my husband look for a woman who really has high desire because mine is so low? Maybe she's confused. I don't know what she feels, but I want to process that with her. And what does she do when she has low desire? What does she do actually in the bedroom at that moment? Does she fake desire? Does she try to do something to elicit it? Does she use pornography to try to heighten it? What does she do outside of the bedroom to try to heighten her desire? Are there good strategies? Are there poor strategies? So I'll ask her those responses. I'll also ask her partner. I'll ask him, what does this mean to you? How do you think about it? Well, maybe I'm a bad lover. That's why she has low desire. Or maybe something's wrong with her. Or maybe, I don't know what he's going to say. Maybe we have a poor marriage. Maybe I've gained too much weight and I'm unattractive. That's why she has low desire. How does he feel? Maybe he feels rejected. Maybe he feels angry. Maybe he feels scared. I don't know what he feels. Maybe he feels, confused about the whole thing. And behaviorally, what does he do in the bedroom and outside the bedroom to deal with her low desire? Does he try to do things to get her in the mood, buy her flowers and gifts to try to get her juices going? I don't know what he does. Maybe he does good things that help. Maybe he doesn't. Maybe he does things that makes it worse. So I want to look at their responses and level of threat. I want to know how they respond to it in terms of threat level. Is this something that actually could jeopardize your marriage, your relationship? For some couples, these sexual issues, if they're not dealt with, it's frustrating, but that's not the most important part of our marriage. It's not going to threaten us. But for other couples, it's a big threat. So I want to know their response on that level as well. Course, intensity. By intensity, I mean pain level. For some people, these sexual problems or difficulties have high pain. And others, it's low pain. It's just a little bit of a bother. But pain and threat are not always correlated. Some people can have clinically high pain about an issue in their life, but it's low threat. I'm hurting a lot, but I'm never going to leave you till death do us part. Others have moderate to low pain, but high level of threat because they're expecting maybe way too much in their relationship. So ask about pain frequency. How often is this an issue? And certainly, are there exceptions? And what could they be? Just going back for a moment, to these responses. Again, behavioral responses inform perhaps a solution-focused response. The affect, the emotion that they're feeling, I could spin into EFT, emotional focus, to get them talking about their feelings and to try to build attachment, a healthier attachment underneath their sexual frustration. If their cognitions are distorted or unrealistic, I could work narrative therapy. I could do cognitive restructuring from a CBT lens. Again, the assessment informs our treatment. And the E in source etiology. I love the work of Gerald Weeks with his intersystem model. Many causes of psychological and relational problems are due to multiple sources and factors: individual, interactional, and intergenerational. So what are the causes of the problem? Let's again stick with the low desire. It could be biological. She's very fatigued, she's sick, she's tired, she's sick and tired. And for many women, when they're fatigued or sick or depressed or ill, libido drops. For guys, it may drop, it may not drop as much. Guys have this tendency to compartmentalize. Even if they're sick, they may still have a high sex drive. Again, it doesn't make them better. It's just different from many women. It could be medications that sometimes lower libido. Psychological issues. Maybe the relationship is bad and that's affecting sex drive. Maybe there's depression, there's anxiety. One of the greatest threats to sexual libido is anxiety. Anxiety and pressure in life in general. And when you have pressure that I got to perform sexually, whatever level of libido I have, it just drops a notch or two. Maybe there's trauma in my life, sexual trauma or other kinds of trauma that makes my sex drive lower than it should be or could be. Maybe there's identity factors. I have a poor self-image in general, a poor body image in particular. Maybe there's interactional factors in our couple relationship. Yeah, I have low drive because I don't like my spouse very much. I don't trust my spouse. Actually, I hate my spouse right now. Okay, there's a lot of conflict. And the last thing I want to do is to be intimate with you. Okay, so that can create another factor. Intergenerational. It could be something from history, from my background, from family of origin, from culture, from ethnicity. Maybe there was a script or a legacy that says for this woman with low desire, women are not supposed to enjoy sex. Sexual enjoyment, entitlement is male domain. You just kind of serve them. That's what women do. And maybe that's a legacy from her ethnic background or from her family background. Or maybe she sensed in her mother and father's marriage, mother really served the father physically, sexually, as well as food and everything else. And it was kind of a one-way street. And she learned that's what women should do. And it should never be mutually giving. A good verse for her at that point would be 1 Corinthians 7, 1-5, which I wish we could spend more time talking about the mutuality of sexual entitlement. So all of these factors, individual, interactional, intergenerational, all flood in like streams flooding this low desire pond. And here's where, folks, sometimes sex therapy doesn't really work because someone in their assessment assessed one polluted stream and kind of cleans it up, and maybe a second one and cleans it up. But that pond is still getting polluted because there's another stream. There's something else toxic that's feeding it, that's untreated because it's unidentified. So this is a very comprehensive, I think, approach to evaluating the sexual problem. It takes a bit of time, but I think it's worth it. So the source model, examining, landing the helicopter among each of the fires and sourcing them in detail. So far we've talked about sexual preference zones, one of the assessments. We've talked about the sex scan, overviewing the sexual issues in general by talking about desire, arousal, orgasm, pain. And we just identified the source model after the sexual scan. Now we want to talk about the secret model. This is a sexual history, okay? Now I'm taking these 6 points about sex history. I have not originated these points. These are common in taking a sex history that's been in the field of sex therapy for decades. So I haven't created them. I've created the silly acronym and put them into this model called SECRET, just so I can remember them. And as I train my students and other therapists, they can have some kind of way to remember. In doing a sex history, these are some key essential points to remember. So shame. I want to know basically, is there shame? Is there a sense that sex doesn't only create guilt, but shame? There's something naughty and dirty about sex or about me as a sexual being. So have you ever experienced significantly unwanted sexual touch or have a significantly unpleasant sexual experience? That is an important question for any sexual disorder or difficulty, not just low desire. Body image. Did this individual grow up liking their body as it developed and matured into adolescence? Did they have excessive guilt regarding any ways that they thought or acted? The sex history goes from pre-adolescent childhood into adolescent, into early adulthood. And I'll do the secret history with a husband, with a wife. I try to have them, if they can, in the same room so they can learn from each other. But again, this is a process. It takes time, but I think it's well worth it. Experience. I'll ask the women their experience about menstruation. Was that a positive experience, a negative experience? Some women celebrate it, others it's gross and weird and confusing. I'll talk about masturbation for men and women. What was that like? Wet dreams, what was that like for guys? Was that positive or negative? I'm looking at the charge of the experiences more than the actual details. I don't need to know in a voyeuristic way, as a 14-year-old when you masturbated, Joe, did you use your hand or a pillow? That's not the point here. The point is, in your history of masturbation as an adolescent, was that a positive experience? Was it a shameful negative experience? Or was it a combination? I'm looking for a charge account in the sex history. If you used pornography, what was that like for you? If you had sexual fantasies or dreams, was that a positive thing, a negative thing? If you had other things that you experienced, that you witnessed sexually, positive charge, negative charge, what was that like for you? Communication. Did your parents talk about the birds and bees? And if they did, was that like, oh, this is good? Or was that, oh, this is embarrassing, don't talk about that? Where did you learn about sexuality? Where did you get your messages from? And when you got those messages, what was the charge? Was it exciting? Was it beautiful? Was it fun? Or was it gross, embarrassing? Oh, I don't want to talk about this. Or was it a mix of both? What were the messages about sexuality from your ethnicity and from religion? Did your church teach positive messages and not just prohibitive messages? We need prohibitive boundary messages, but also we need positive messages about the beauty of sexuality that sometimes the church is all too silent about. Were these messages, wherever they come from, positively charged or negative to you as a child, as an adolescent, as a young adult? Your relationships, I may ask about your first experiences, your first dating experience, your first kiss. Was that wanted? Was it coerced? Was it mutual? Your first sexual experience, whatever that was that something you wanted? Was it coerced? Was it positively charged? Was it gross? Was it negatively charged? I'm looking for patterns of experience throughout their sex history, more than actual details. Now, sometimes we need the details, especially if we're doing sex trauma work. But at this point, we are just getting a history, and we're looking more about the level of shame or the level of disgust or the level of joy or positivity about someone's sexual life and development. Their emotions. I will ask about how you felt about sexuality, how you felt about sexual communication, about your experiences about your body. Positive emotions, negative emotions, what kind of emotions? Fear, anger, confusion, shame, disgust. And what were your thoughts about sexuality growing up? Your thoughts about different kinds of sex, different expressions of sex. Your thoughts about pornography, your thoughts about, what were they like? Were they positively charged for you or negatively charged or mixed? All right, so I'm doing a sex history for both the male and the female in this relationship, in this heterosexual relationship. And again, I'm looking for the charge account. Overall, are there negative charges as a composite, or on this side, are there positive charges? If they're primarily negative, there's a good chance, even if they're married and they love each other, a lot of that's going to go into the marriage. It doesn't mean you're doomed to have negative, shameful sex in your marriage, but it means you're set up to be vulnerable for that. Maybe that's not going to happen. And sometimes if you have positive charges, and maybe more positive than you should, it can also create problems. But I want to understand how the history informs the present issues that my clients are bringing, because there is a historical context that informs the clinical issue in terms of both assessment, how it's become a problem, why it's become a problem, and the treatment. How do I address it clinically with my clients? So, in conclusion, here we are. We've talked about 3 domains and 3 levels of sex therapy. We've talked about 4 assessment strategies. And so overall, these are the 4 things that I think can make comprehensive sex therapy assessment. So my final thought is just the encouragement to do good sex therapy assessment. It takes time. I'll tell clients that the assessment phase for sex therapy can be anywhere from 2 to 4 to 5 sessions. It's going to take time. Now, if they're impatient with that, I might give them some interventions to build relational connection or to do some communication. I might give them some surveys to take or assessment instruments that will give me some of this data quicker than an interview. But I find in the interviews, you learn so much about the processes in the relationship that is so informative for doing clinical work. So again, sex therapy is hard. It becomes more difficult when sex therapy assessment is poor. So I encourage you to take your time, do the work of detailed sex therapy assessment. And I hope these strategies and thoughts have been encouraging and helpful and informative for you. I appreciate your time with me in this presentation today. And I wish you God's best and blessing as you continue to work with this area. Sexuality is an area where therapists need to work with clients. Those who have a Christian worldview can reclaim the beauty, the glory of sexuality as God intends it, with both eroticism and sacred boundaries. So we will have a time of Q&A as we conclude. But again, I want to thank you for your time with me today.